Good morning, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. Today is Wednesday, December 30th, and it is our last Facebook Live of the year. We've done well over 100 of these this year, and certainly have enjoyed getting a chance to answer your COVID questions directly. So as always, you will have the opportunity to put those questions directly into the box below, or do hashtag AskDrArwady on either Facebook or Twitter. We've been getting a lot of vaccine questions in, and so most of our conversation today certainly will be about the vaccine. But before we get into questions, let's take a quick look at the dashboard. As always, chicago.gov/coronavirus is your landing page for everything related to COVID in Chicago. Up at the top of that page, you'll see tabs that will lead you to vaccine information. Actually, if we pull it up right now, I can show this. You can see the tabs here. If you want to see more about vaccine, go here. Testing, go here. Contact tracing, latest data, Protect Chicago, that's our outreach initiative, other resources, updates. But right under latest data, the very top thing here is the COVID daily dashboard, and that's what I've got pulled up here. So if we look at the COVID daily dashboard, let's just let that reload. We can see that we are making some very good progress here in Chicago. First of all, our positivity rate is down to 8.3%, and that's what this purple graph is over here to the right. If we blow that up for a second, you can see that after peaking in November at about 16%, we'd gotten down to about 11%, then this was our post-Thanksgiving surge, and we've been on a really nice decline here, down to 8.3% today. We want to get down under 5%, but considering we were at 16% in November, we are making really good progress, and thank you to everybody who has been really working and doing the right thing and helping prevent the spread of COVID here. Our testing average is at right around 14,000. That's a 7-day rolling average. You can see that's actually been pretty steady after the Thanksgiving drop. So the good news is the changes here are not being driven by significant changes in testing. And exciting, our daily case average is at 971. It's under 1,000 for the first time since the very beginning of October. That again is a 7-day rolling average. And if we look at what that has looked like over time, I'll go to the daily by demographic. That's this here. You can also see really nice, this is the rates, really nice. There was our Thanksgiving surge, but then it's been on the decline, really going well day after day. We'll know really over the next week or two how much of an incline we may see again post end of year holidays. But then, we again are heading the way that we need to head. Over the summer here, this is where, if you'll recall, our goal is to stay under 400 cases and ideally under 200. So we're still well over twice that, but heading the right way. Deaths also, you can see we're averaging 16 per day. Down from 21 per day was our average just a week ago. So hospitalizations, everything is heading the right way right now. But we really, it's still for New Year's, please make alternate plans, don't gather. We still have a lot of COVID here, and we need to be protecting this progress. I want to be at a point in January where we can actually think about some more reopening. And if we can stay on this trajectory, I think we'll be able to do it. But a lot depends on really what happens over this next week or two. We're in a much better place than we were at Thanksgiving, where the risk was so much higher, even of any gathering here, but the risk is still high, and we're still, well exceeding cases, positivity, and deaths. You'll see we're going to end out the year here most likely just under around 200,000. So that's 200,000 cases of COVID-19 diagnosed in Chicago this year, and well over 4,100 deaths just this year. We've done 2.3 million tests. So I encourage you to explore some more if you're interested. But let's go ahead and turn and start to get into some questions. Okay, lots of things coming in. So, right off the bat, someone's wondering about my own vaccine. So people who watched the press conference yesterday may have seen that I got my COVID-19 vaccine, the first dose, yesterday at our city pod. That's our term for a point of dispensing or a mass vaccination center. We opened the first one of those at Malcolm X. That is only for outpatient healthcare workers, meaning non-hospital-based healthcare workers, it is only by appointment. And what we've been doing is expanding out the appointments that are available to different groups of healthcare workers. So we'll talk some more about that. But to inaugurate that pod, I am an outpatient healthcare worker. I see patients. I've been seeing patients at, it's called Community Health. It's our largest free clinic in town here for probably 7 years. And in that context, I was able to get my first vaccine. It didn't hurt going in, and the only side effect that I've had is that my left arm is a little bit sore. It started to get a little bit sore yesterday afternoon. It's still a little bit sore today, but honestly, it's less sore than I tend to get even after a flu shot or other vaccine, and I've not had other side effects at this point. I had a little bit, just a very beginning of a headache yesterday, and I was like, is this related to the vaccine? And then I ate lunch and it went away. So I think I've been really pleased. And we do know that some people certainly do have some side effects, that people will report a sore arm, but also people often will report feeling more tired or having a headache or having muscle aches. I am also enrolled in what's called the V-Safe program. It's an optional program through CDC where every day I get a text message and I report in any symptoms that I'm having, any concerns that I'm having. It checks in with me every day for, I believe, the first week or two after vaccine, and then it continues to check in 3 months, 6 months, 12 months out, just to make sure there's no concerns. So I was very pleased to get that vaccine yesterday and feel really good about it because every time somebody gets a vaccine in Chicago, of course, it is taking us one step closer to us getting back to a new normal. And I've been anxious to get this vaccine, as I know many of you are, but I really didn't want to skip my place in line. I wanted to make sure I waited until it was time for outpatient healthcare providers to start. And that is really what I encourage all of you to do. I talked yesterday a little bit about how this has felt like a year of waiting in so many ways. We've been waiting to get back to all the things we love doing. We've been waiting to gather with family. We've been waiting. And I know how hard it is to feel like we're still waiting at some level for this vaccine. But the rollout's been going really well here, and we'll get some more questions. Okay, so CPC4 Chicago on Twitter is saying, why hasn't vaccination data been updated since 12/27? Also, the 12/15 number was lowered from 5 to 4. Is this because one of them wasn't a Chicago resident? Yes. So let's talk about the details of both of that. So when vaccine is administered in Chicago, the people who administer the vaccine, meaning the doctors or the nurses or the points of dispensing or the pharmacies, they are supposed to report that information into the state registry. They have 24 hours to do it. Now, this is a new process for some of them, so in some cases we're seeing it is taking them a little bit longer than that to get the reporting done, and we're following up and just doing a little bit of checking behind the scenes. And then right now it's also about another 24-hour lag for just doing all the processing really at the state level so that we're able to pull the data out. We've been working to increase our ability to access that data directly. If you look on under that latest data tab, you can see. Actually, maybe I should have pulled this up, but you can take a look yourself, and if people have questions, I'll show you how to do it. You can pull up and see what our vaccination numbers have looked like day over day and what they're looking like by the map. Now, to the point of this question of why was the 12/15 number? So we started vaccinating on 12/15, and as you noted, we did those first 5 doses at Loretto Hospital, but it shows that we only did 4 doses because one of them is not a Chicago resident, and that's one of the most important things to know. If you've been following along with us all along, the way public health works is that all of our reporting is done by the jurisdiction, meaning the city or the county where somebody lives. So we do that so that people, and that's true all over the country, so that you don't accidentally count somebody twice. You don't say, let's count them as getting vaccinated where they live here and where they work here. All diseases, all reporting across all of public health is done by where the person lives. So one of the reasons, we've gotten some questions, and I see some here about, why are you only showing 20,000 doses, for example? I know there's more healthcare workers, there's been more at hospitals, and that's because we are only reporting there on the number of Chicago residents vaccinated. And it turns out there are a lot of non-Chicago residents who work in Chicago healthcare, and particularly in our Chicago hospitals. So that very first day, one of those people was not a Chicago resident. But we do not prioritize people who are Chicago residents. They're here. they're working, they're taking care of Chicago residents, and so we want to get the highest risk people vaccinated first. So if someone doesn't live in Chicago, but they work in Chicago and they're getting vaccinated through their place of work, no problem. It also works the other way. If there's a Chicago resident who works in suburban Cook County, maybe they work at Loyola, or they work at West Suburban, or they work at Advocate Christ, right? These are hospitals that are very near us, but technically not in the city of Chicago. They get vaccinated at their place of employment, but their vaccination would count in the city of Chicago. So we count at the end of the day based on where people live. So it means that our numbers here will look perhaps like they're lagging a little bit, but we're doing a lot more vaccinating than you see. They all show up, though, in the state data. And actually, we've been getting some good kudos nationally, both for Illinois and for Chicago, that we are among the very top states in terms of having already gotten vaccine actually into arms, not just distributed, but into people's arms. And I think we were 5 where I was looking at this most recently, but we've been really in the top 5 or so, both in terms of number of vaccine and when you look by population. So the rollout's been going really well. We also, and there's some more questions. I thought I saw another question about that. Yeah, so P squared 20202 on Twitter is saying there's much discussion now of the nation's slow vaccine rollout, the potential that vaccine doses may expire before they are used. How is the city addressing that issue? So a couple things on this. Number one, we are pushing this vaccine out absolutely as soon as we receive it. We have pushed out in the city of Chicago more than 95% of the doses that we have received, both for Pfizer and for Moderna. We have fewer than 1,000 Pfizer doses that are sitting in our warehouse right now. We use those in our central points of dispensing. We have just a little bit more than that of Moderna because we're distributing Moderna to outpatient practices as they're able to sort of get all their paperwork done so that they can do some direct distributing. But we are pushing this out absolutely as soon as we can. All of the vaccine, the Pfizer doses that we received this week went directly to our hospitals who are continuing to vaccinate. About 94% of our Moderna doses this week went directly to long-term care facilities because we also started vaccinating there. And then just a little bit of the rest of the Moderna is to get us started in some of these outpatient facilities. Outpatient healthcare workers here are really going to ramp up in January. And we can talk about that some more. There is no concern that vaccine doses will expire before they are used. These typically have about a 6-month expiration date on them, and we're using them within days, not within months. So there's not a concern related to that. We're also doing, we don't just, we distribute the vaccine, and then there's a reporting system on the back end where we can see how many vaccine doses are being used. And obviously, we're thinking a lot about equity, making sure that we're getting this distributed across the city, giving extra support to smaller locations that may need it. But also, we are looking to make sure people are using that vaccine up. We distribute vaccine based on appointments at this point. So if a hospital, especially the smaller hospitals, are able to say, I have 200 people signed up for a vaccine clinic this week, we give them their 200 doses. So we're working really hard to make sure that vaccine's not being wasted, not expired. And I've been very pleased with how this initial rollout has gone. I do hope, though, that the vaccine that we are allocated increases. It is all being allocated based on population, which makes sense. But my hope is that as more Pfizer and Moderna vaccine, as they are ramping up their production processes, we get more here because, this week, we got a total of about 30, we got 21,450 Pfizer doses and then 16,200 Moderna doses. That's what, 37,650 doses. Looks like we're getting about that amount again the following week. We can certainly be distributing a lot more than that. And so I'm really hopeful that as production ramps up, we'll be able to pull this out, to move this out faster. And I saw a question, Fierce Finder on Twitter is saying, can you speed up the distribution of the vaccine? Instead of targeting to begin phase 1B in March, can you complete phase 1A in January and begin 1B in February? I think we actually will probably begin 1B in February, but it all depends on how quickly this vaccine gets here. We know, there's hundreds of thousands of healthcare workers in Chicago. We will not finish healthcare workers before we start 1B, realistically, but we do want to make sure that we've gotten through sort of the bulk of them. So January is going to be all about phase 1A. And for those who maybe aren't following the phases as closely, what this questioner is referring to is that the CDC and the Advisory Committee on Immunization Practices has set phase 1A for all healthcare workers and long-term care facility residents. So that is who we are vaccinating first. That is who we have started with. We started with hospital-based 2 weeks ago. We added in our EMS paramedics that are out helping transport people to hospitals. And then just this week on Monday, we launched long-term care facilities and outpatient providers. And the outpatient providers are a mix of sending vaccine directly to some of the, beginning with, again, the highest risk outpatient settings, meaning the ones that are doing a lot of COVID testing and diagnosing a lot of COVID. But over January, we will be expanding this further so that more and more and more clinics will be able to directly receive vaccine, to start with vaccinating just their own staff, to be clear. Nobody's vaccinating patients yet. This is really about getting healthcare workers vaccinated, but it sets them up to be ready to go as soon as we can move into 1B. We start vaccinating older Chicagoans, we start vaccinating people in those frontline essential workers. We want to have as many providers enrolled and ready to go, trained, knowing what they're doing on storing vaccines, so that as we move into 1B, that can be just as quickly as it can. So really the question of kind of when can we move into the next phase has to do with how much vaccine we get. Where I'm hoping that's going to really ramp up a lot because we have a lot of healthcare workers here. But we will, I'm expecting that probably in February, probably later in February, is when we'll move into 1B. We'll have a better sense of that once we see how much vaccine we're going to be getting. But we're doing all the planning right now, not just for 1A, but really for 1B. There's no more groups to start in 1A. We've started all the groups. It'll just be, January is going to be about continuing to expand access for outpatient healthcare providers. So we'll be adding all the dental offices. We'll be adding all the, eye optometrists and ophthalmologist offices. We'll be adding the morticians. We'll be continuing with home health. We'll be continuing with the doctor's offices and the urgent care, and all the behavioral health people are very much in there. So there's not really, I wish there was a way to speed up how quickly the vaccine was getting here, but there's not. And again, we have pushed out already, more than 95% of the vaccine that we've received. And that is our goal, to really continue to do that. I don't want to sit on vaccine. I want it out and being used. Okay. Ulsana O from Twitter says, can you share your perspective on the news that the UK has approved the use of the Oxford AstraZeneca vaccine? Do you anticipate it will be approved in the US, and would the US require a trial specifically looking at the efficacy of only one dose? Okay, those are all really good questions. So that was the news just this morning, that the UK approved the AstraZeneca vaccine for use. And because the UK did, there's a good chance the WHO probably will as well. So a couple things are different here. Number one is that the UK has not had access to the Moderna vaccine. They've only had access to the Pfizer vaccine, and that is the one with the ultra cold. It's a lot more complicated from a distribution. It's hard to use in rural areas. It's harder to use in outpatient settings. So they have been particularly anxious to get a vaccine available for the population that is a little bit easier on the distribution front. And to this question of, would the U.S. So, my thought here is that the trials are still continuing. There are trials in the U.S., there are trials around the world, and the FDA will continue to use the same process that it has used to already approve the first two vaccines. There's a certain amount of safety. You have to follow people for, at least 2 months after they've completed the vaccine series. You have to, have done a certain amount of enrollment. You have to show a certain amount of efficacy, and most important, high safety. So when those things have been met, the FDA would consider the AstraZeneca vaccine just as it will any of the other vaccines that are coming along. This one dose question is interesting. The FDA, and really any regulatory agency, does look at the data based on how the vaccine was used in the trial, right? We don't approve a vaccine for use off label from how the trial was done. But what you're referencing, I think, is that there was this interesting piece where some of the people in the trial got dosing kind of at different times, and there looked to be pretty good efficacy after one dose. And in the UK, they are concerned about this new variant that they have spreading, and there's a lot of desire to really ramp up vaccine. And so what I was reading this morning, and I'll be reading more about this, is that they are planning to really do a big push for a single first dose and try to get a lot of that out. And then they're saying maybe we'll just be looking for a second dose within 12 weeks because they are really concerned about that variant and wanting to get started on vaccination. We here in the US, I think, at least so far, we've got 2 vaccines, including one that, although it still needs the frozen state, it's not quite as hard as the ultra cold Pfizer. The nice thing about the AstraZeneca one is that it only requires refrigeration, meaning it doesn't even require frozen state, and it's a lot less expensive to produce. It's not the mRNA, it's a more traditional way of making vaccine. So what they're saying is this will be a vaccine that will be really important for use around the world, where it's hard to keep things frozen, where you're thinking about distributing in developing countries, et cetera. So, and it's only about $2.50 a dose, whereas the mRNA ones can be like 10 times that cost. So I think at some point we probably may see the AstraZeneca approved, but I don't think that will be that imminent here. We want to make sure, of course, all the safety and efficacy trials are done. So good question. All right, Simone Downs on Facebook is just one of the people asking about this UK strain. Simone is asking, what do we need to know about the new variant of corona? The vaccine would need to be able to combat all variants of the disease. Johnny Banks on Facebook is saying, Colorado witnessed its first case of the new disease. Do you believe it's here in Illinois? And at Parent CPS on Twitter, what are you hoping to learn soon about the UK strain and some early reports that kids may be more likely to catch and transmit it? Okay, so let's talk about the UK. So first of all, as a reminder, those of you who have been following along know that we have been seeing some mutations in the coronavirus all along here. Mutations are not surprising, and they're not necessarily bad. We actually expect that with the size and the type of virus that the SARS-CoV-2, the virus that causes COVID-19, we expect to see about 1 mutation every 2 weeks or so, and we actually can use that genetic fingerprinting to understand, how the virus is spreading. What got a lot of attention in the UK is that there is a variant there, meaning not actually a full strain in the medical way that we use that term, but a variant that it's actually 23 different mutations that have been suggested in modeling to make that particular variant more transmissible, meaning potentially more easily able to spread. The good news so far is that, number one, it doesn't seem to make anybody sicker. It doesn't seem to put them in the hospital. It doesn't seem to lead to more likely to death. That would be one of the things that I'd be most concerned about. And secondly, most importantly, there's been no sign at this point that any of the existing vaccines or the vaccines that are in trials would not work against this variant. They're still working on that, and obviously testing, and you want to be really sure of this. But we, I knew there was no chance that we were not going to find that variant here in the US. As soon as I heard that it had been circulating in the UK since at least September, and that there were at least 6 or 7 countries that had identified it, clearly we would identify it. We do have, a number of our institutions here in Chicago, the larger academic hospitals, do some of this genetic sequencing, and every time a SARS-CoV-2 is sequenced, meaning we actually look for mutations, those are uploaded into a public database. So this has been a worldwide effort where we think about scientific cooperation from the very beginning. The fingerprint, the RNA fingerprint, the literally base by base by base, looking for mutations. There's been more than 250,000 uploaded around the world. Last I looked, about 55,000 of those were in the US. The UK has actually done the most uploading of sequences there. And we've been working to do more and more uploading here. And the CDC has been also actually increasing the number of actual viruses that they are doing that genetic sequencing and uploading. We also here in Chicago, actually just even before we knew about this variant, we had used some of the initial federal funding, and we put out a request for proposals, which is basically like a grant competition, to look for one of our people in one of our institutions in Chicago to be a regional coordinator for this kind of genetic, not just for COVID, but really thinking more long term. How do we do more molecular infectious disease work like this? And Rush won that contract. So it's about $3 million, and they will be serving as a regional coordinator, working to really increase this kind of surveillance, meaning that we're looking for changes in the virus or even in other viruses. We have more ability to what's called biobank, meaning store samples in case over time we need to go back and look for changes, and then do some of the bioinformatics, some of the computer work that you need to really analyze and look for change. So we've been looking for it, here to an extent, and building that. But at the end of the day, I mean, it's concerning because where we see COVID pick up any change that could lead it to be more successful, it's a concern. But it doesn't seem to, again, because it's not, the vaccine doesn't look like it's going to be a problem at this point, and it doesn't seem to make people sicker. As long as people are doing the things that we already know work, the 6-foot distancing, the masking, the hand washing, there's not a reason to be significantly concerned that we'll see, major changes here. Time will tell. We're certainly monitoring, but I think it's just one more variant of the many variants that are seen. And we'll be learning more. There are animal studies being done right now. So all of the work in the UK has really been done around modeling, and they're doing some animal studies to say, is it actually true that this variant looks like it can infect more easily? So we'll know a little bit more about it in the days to come. So do I believe it's here in Illinois? I think it's possible it's here in Illinois. I don't think it's here in Illinois in large numbers, but regardless, it doesn't change any of the guidance or what we need to do. So I think knowing that there are strains that could be more concerning is not a surprise, but it's a reminder not to let our guard down even as we're getting started with vaccine here. And to the point about kids maybe being more likely to catch it, like that is all speculation and modeling at this point. So I think it's way too early to call on some of that. Again, a lot of this work is being done in the UK, and we'll be learning some more about it. But it doesn't change for me anything that we're doing here in terms of either response or messaging, besides making sure that we're increasing some of that molecular surveillance. But it's just a reminder to people to continue to, be careful, wear your mask, don't have folks over, all of these things that we've been talking about. Okay. So Windy City 3 on Twitter is asking, why the push to return prior to vaccinations of CPS staff with the holidays and maybe spikes? So educators are in phase 1B, which we are pleased about. They're one of about 8 different groups that have been prioritized by the CDC within phase 1B in the frontline essential workers. But where we the decision around returning to school doesn't have anything to do with vaccination. It has to do with the fact that we have seen, not just here in Chicago, but around the country and around the world, that it is absolutely, we don't see schools driving community spread. We don't see them as significant sources of infection. Where we looked at our archdiocese data here in Chicago, we found half the rate of infection in kids who are in school compared to the ones who are out, and similar rates of infection in the staff compared to adults in the community. So where schools are being careful and are doing the masking and doing all the right things, they've not been shown to be significant sources of spread. Just like offices, places where people take this seriously have not been a big concern. And so it's been a very data-driven decision. Vaccine will certainly be rolling out to CPS, but if we think about this maybe beginning, in potentially March, for example, and then you do a first dose. If we're doing Moderna, a second dose is a month later. You think about 2 weeks later. I mean, we really are getting to the end of the school year before we would think about really, being at a point where you would have a lot of protection there. There will be testing available, and there is no world in which I would be supportive of CPS coming back if I did not think that CPS had done all of the things that were necessary and more to have a safe environment for staff and for children. And I'm really confident in the plans, and I've been really worried by seeing the inequities in educational outcomes, and particularly in the pre-K and special needs kids, which are the first students that are coming back. So that is, as you know, that's been planned for some time. Okay. John Boggs on Facebook says, I'm a teacher. When it becomes time for my vaccine, how is it going to be administered? By school or by my own doctor? Okay, so I don't know what kind of school you're in. I don't know what system you're in, but I can speak a little bit more broadly to essential workers in 1B. And this will be a combination of things. Certainly, we will be working very hard to make vaccine available through employers in phase 1B. We'll be pairing up schools, either if they have nurses and the ability to do their own vaccination, we will be providing vaccine directly to schools and the training and everything to allow them to do the vaccination for their own staff. If there are schools that may not have that capacity, they can pair with a vaccinating partner, but we absolutely want to make vaccine available through employers as much as that is possible, especially larger employers in phase 1B. So just as it's true for schools, it's true for grocery stores, it's true for large manufacturing places, it's true for our transit workers and our first responders and all of the other groups that are in 1B there. We'll be doing a lot of push to pair large employers with vaccinators. But we recognize, just like in 1A now, we're sending vaccine directly to the hospitals who are very large employers and to some of the larger, we're starting with some of the larger outpatient clinics, and we'll keep moving from there. We know that there are a lot of smaller daycares, for example, right? You might have a daycare that has just, 5 staff or something. Those folks, we will be more likely to either having be get through their doctor, or we'll be working to get them set up with pharmacies that are nearby, with strike teams, or with our large central mass vaccination pods. So just like in 1A right now, we're in healthcare workers, those are only open by appointment for healthcare workers. In 1B, we'll be thinking about essential workers as much as we can, pairing employers with vaccinating partners to make it as easy as possible, lower those barriers, especially recognizing how hard hit these frontline essential workers have been. They're in some of our hardest hit communities. I want to do everything I can to take all the barriers away there. So, you never have to pay for a vaccine in the city of Chicago. You never have to have insurance. You never have to, show any immigration status information. You never have to show identification, although you have to give some information so that we can know about second doses. We want to really make it as available as they can. So what we'll do is a grocery store, the larger grocery stores, some of them have pharmacies within them, and that will be a relatively easy match. Some of the smaller ones may not have a pharmacy within them, but we may strike team them or bring someone in. But then some of the very smallest ones, we're more likely to get connected to a pharmacy in their community, one of our central pods, et cetera. So that's kind of how it will work. So not knowing your details, you could get it through your own doctor. We will be especially encouraging older Chicagoans to be getting it through their doctor. Like, that's going to be really the main push. It will be open for essential workers also through their doctor, but we'll be doing a lot to try to push vaccine through employers in 1B. Okay, Drew Clausen from Facebook. Can vaccinated people still spread the virus? I have heard mixed responses. When will we know for sure? Okay, so couple things in this. First of all, let me just start from one statement, is that it is absolutely impossible for someone to get COVID-19 from the vaccine. So there is no live COVID-19 virus, there is no killed, there is no inactivated. It is impossible for someone to get COVID-19 from the vaccine. So if someone has been vaccinated, there is no chance of them spreading COVID-19 to others as a result of having been vaccinated, because it is impossible for themselves to have been infected, if that makes sense. I think what you're asking is if someone has been vaccinated and then they get COVID-19. So remember, your first dose, like even though I got my vaccine yesterday, we know that I don't immediately have, immunity to COVID-19. It takes time, and really after that first dose, Pfizer estimates I have about 52% protection from COVID. It's really only after that second dose that it jumps up to 95% protection from COVID. And so we, although there is no chance that I can get COVID from that vaccine, if I were to be exposed to COVID, right, in the next, particularly over this next month, and I got COVID, we are still learning whether it's possible for someone to have, asymptomatic COVID, for example, particularly if they started vaccine, and still be able to spread it. And we're still learning a little bit post the second dose. So one of the reasons why I continue to wear my mask, I continue to social distance, I do all of these things, first and foremost is because I don't even consider myself to have any level of protection. I start to have a little bit, but in terms of changing the way I behave, I don't change a thing until at least, a week post that second dose. So this is more than a month from now before I would even start to feel like, okay, maybe I have some protection. And even then, there is no such thing as a 100% protective vaccine, right? Like a 95% protective vaccine is a fantastic vaccine, but 5% of the people still were able to get COVID. It was also protective against severe COVID, and that's really important, that it's looked like, even if there were a few people in the trials who got vaccinated, were able to get COVID, they were not likely to get hospitalized, didn't see deaths, that kind of thing. But what we're still learning, and the trials are ongoing, is if there are still some people who get exposed, are able to have really asymptomatic COVID, is there some potential for spread? So that is what we're still learning about. But the experts generally think it should be protective, but we want to see that for sure. And we'll be sharing some more about that probably over the next month as that next data from the trials comes out. And Deborah Schechter on Facebook is asking the same thing. How will it be determined if the vaccines protect from someone spreading? So first and foremost, remember, if I'm 95% protected from getting COVID, that is, number one, that's for me because it helps me keep from, getting severely ill, et cetera, et cetera. We will, because what they're doing in the studies is following up people, not just, the earliest studies were a lot about, did you develop any symptoms? Anybody who developed symptoms they were testing for. But what is ongoing in a more long-term way, which is really what we're most interested in, is they're doing nasal swabs of everybody, regardless of symptoms, who are in the trials to see, are you possibly picking up COVID? And the earliest data actually did continue to look relatively protective, even against sort of this asymptomatic COVID, but it was too early to call it. So this is where there will be some more data coming out, probably over the next month or so. Leonard Chin from Facebook, is the second dose the same as the first dose, or are we getting a Part A and Part B vaccine? So good question. For both the Moderna and the Pfizer, the first dose and the second dose are the same in terms of they are the same dose of the same vaccine, but they work slightly differently in that first dose is really to prime your immune system, to teach it to start to recognize the COVID, so that it teaches it how to recognize that little spike protein that's on the virus that we've talked about, and tells my immune system, in case you encounter something with a spike on it, this is how you need to start fighting it. The second dose that comes either 3 or 4 weeks later, depending on the vaccine, is really that booster dose that sort of says, okay, now that your immune system has been primed a little bit, it's been taught what to look for, here's another very low dose, not of virus, but of another kind of lesson for your immune system that helps it rev up even a little bit more and then gets you sort of full protection. So if you think about, it's not uncommon. A lot of our vaccines, especially the childhood ones, are a series of vaccines, like the tetanus vaccine, for example, that we give to children. You need 4 or 5 doses of that before you're actually done being protected, and it's sort of teaching your immune system over time and giving you these little boosts, an additional lesson. So you do need both doses to be considered protected, but it is the same information and the same ingredients that are in the vaccine. If anybody's curious about ingredients, our last Facebook Live, we spent 10 minutes talking about the details of exactly what is in all of these vaccines. Mike Chinnander from Facebook, was there a coordinated attempt for various vaccines to work on different parts of the virus, e.g. not all the spike protein, so they wouldn't be rendered ineffective by a particular mutation? Okay, good question. I want to be clear that these vaccines, it's not like there's one instruction to make a spike. Even the Pfizer and the Moderna vaccines are focused on just one little piece of that spike. And so certainly they are not all the vaccines are not working in exactly the same way. This is one of the strengths of actually having multiple vaccines that are being developed coming along. A lot of them are focused on spike protein at some level, because it's one of the things that the spike itself is like how the virus gets into your cell. So if you can help really work on that spike, it's good from a recognize me because I'm unusual to the immune system, but also it's good because it helps really work against the way that the virus actually gets in. But each of them are somewhat different. And in fact, although the first two have both been messenger RNA, all of the other vaccines that are coming down the pike, they're not messenger RNA. They're using slightly different technologies. And this is where I think having additional vaccine available is going to be really, really helpful. And this is like the AstraZeneca is a different approach. Okay, we are almost out of time. Let me see if there's just a quick one. Guadalupe Gallegos on Facebook. If you develop antibodies to COVID, do you still need to get the vaccine? Yes. So this is a question about if you had COVID and you've recovered, you definitely should get the vaccine. The antibodies that you develop related to natural immunity, we think they don't last that long. CDC has said we think they probably last about, maybe 3 months, it may be longer, but it's much less predictable. The vaccine has been developed to give your immune system, a lesson, like with a very particular dose that develops, that leads to a predictable immune response. And it's not all about antibodies. There's antibodies in B cells and T cells. Some of you know I've been making these science behind the vaccine little videos, and we're actually going to do one next week about a little bit more about how your immune system works related to vaccines. So I'll be talking and drawing some pictures about that, but the bottom line is you definitely want to get the vaccine. You don't want to count on sort of natural immunity. So good question. And Jean Brooks on Facebook, I think these will be our last one. Well, there's two more quick ones. Jean Brooks on Facebook says, when mass vaccination begins, how will people be monitored for allergic reactions? So not just when mass vaccination, but already all vaccinations that are done require a minimum of 15 minutes of observation and 30 minutes for anybody who has a history of allergic reactions. So yesterday, when I was out at our mass vaccination site, I was looking over this. Like half of the space is being taken up by the chairs that people need to wait in for their waiting period. We have all, and we're ready for this anyway. Like it's not unusual for a very tiny percentage of people to have an allergic reaction. Whenever I even give a flu vaccine, even one dose of flu vaccine, like the Chicago Department of Public Health sends me with not just the one dose of flu vaccine, which I mean I would do that like for a media person or the mayor or something. It always comes with even one dose. It comes with the medicine you would need in case somebody unexpectedly had an allergic reaction. So it's something we're prepared for. And for example, out at Malcolm X, we have not only the medicine that you would need, we have it sort of pre-drawn up in case we were to need it. We have EMS personnel in case there were to be an issue. We've thought through the details of what that would look like. We don't anticipate it to being a problem, but we are absolutely prepared in case somebody does have an allergic reaction. And the last one I'm going to take, Ava Meza on Facebook. Are the vaccines currently for 16 years old and older only? Yes. So no vaccines have been approved for children, even under emergency use authorization, and I do not expect any will be approved for children probably until this summer at the earliest, because the trials are not done yet. There have been trials that have been started for kids as young as 12 and maybe as young as 10. I've been keeping an eye on this. But there needs to be the very rigorous safety and efficacy work that we do for all childhood vaccines before we'll be comfortable recommending these for kids. So the Pfizer vaccine has emergency use authorization for people over 16. Right now, it would only be for healthcare workers who are over 16. And the Moderna vaccine is approved for people over 18, has emergency use authorization for people over 18. So that will be my last question. And all these good questions coming in, and we just don't have time. Cityscape Scap on Twitter. When will mental health providers in Chicago be able to get the vaccine? January and February. All healthcare providers in Chicago will have vaccine available to them in January or February at the latest. Okay, we truly are out of time, but I want to wish everybody, first of all, a happy new year. I know we are all excited to put 2020 behind us, and I do think 2021 is going to be a year of real progress here, not just on vaccine, but being able to really get back to this new normal over time. I'm really, it's a lot of work, but I'm really looking forward to it. I also just wanted to note that while Chicago Public Schools are on winter break, if there are any CPS families that are needing meal assistance, there are kits that contain 4 days worth of breakfast and lunch, and you can pick them up at over 125 meal sites across the city. Go to cps.edu/meal site finder in case you or anybody you know is needing some assistance with that. And I think with that, I will wish you a happy new year. We will be back next week, regular time, Tuesday and Thursday at 11, continuing to talk about vaccine. We're doing a lot of recording of smaller vaccine questions. If you've got questions that were not answered, I encourage you, check out chicago.gov/coronavirus. Right up at the top, that vaccine tab will get you to a ton of information. Like 80% of the questions that I'm seeing here can actually be answered off that website. And you can also get there directly by going to chi.gov/COVIDVax, COVIDVAX. I will, and I'm sorry I couldn't get to everybody because there's a lot of good ones in here, but we'll do some more next week. And where you are putting these in, if we didn't get to them, we're working to turn them into frequently asked questions on the website too. So please explore there. Happy New Year, and we'll see you in 2021. Bye-bye.